Lung cancer has always been stigmatized and to a degree ignored. When the new targeted therapies came out, I recognized that they could really bring some hope to patients with lung cancer. My colleagues and I came to the agreement that pathologists are well suited for ordering mutation tests and handling the information. As pathologists, we make the diagnosis, and it is easier for us to organize the transport and triage of tissues. All of these factors put us in a good position to organize mutation testing. At Sunnybrook, I set up a dedicated email address for requesting a mutation test and made sure that this address was included in every patient report. Once the results came back, I relayed them to the clinician as an addendum to an already issued report. For patients who were referred to Sunnybrook after they had been diagnosed, we trained intake clerks at the Odette Cancer Centre to read the referral reports and recognize key terms, such as non-small cell lung cancer, so that they could identify patients who needed the test on intake. Both of these simple steps sped up the process and had a significant positive effect on patients. The whole process of getting everyone on board, implementing the email system, training the intake clerks, only took a couple of months and was not as difficult as one might expect. By the time I came to North York General, mutation testing had been fully funded by Cancer Care Ontario and was no longer being funded by pharmaceutical companies. This was vital, given that funding is by far the biggest barrier to introducing new tests in a hospital lab. I was also quite familiar with EGFR and ALK testing, and as a result, the introduction of reflex testing was much easier. In reflex testing, all patients with a non-small cell lung carcinoma automatically undergo mutation testing, instead of a clinician individually ordering tests based on cancer stage. This eliminated the idea of using a dedicated email address to tell the pathology department when to order the test. Convincing the pathologist in the department to make these changes was relatively straightforward, because by then we had data showing that reflex testing reduced turnaround times for mutation tests, and this is often important for non-small cell lung carcinoma patients because of their short life expectancy. I also think that being the chief of the laboratory certainly helped convince people. I have certainly also received a lot of positive feedback from other physicians in the hospital regarding this change. Every time there is a transition from one method to another that involves new responsibilities, there is always a bit of concern about how much more time the new approach will take, how much more paperwork might be necessary, or how many more resources it will require. Given that the medical oncologists were the ones responsible for ordering mutation testing in the past, this was something new for the pathologists. The old idea was that a physician would need to be in direct contact with the patient in order to know who should be tested. I really had to convince people that this new system could be used just as well and could even be done a bit faster. Naturally, a few people were less receptive than others and needed some convincing, but in the end, it worked out fairly easily. I've visited a number of hospitals and spoken to many physicians, especially pathologists, about the approach and have tried to bring this system to other hospitals. It is important to recognize the differences between hospitals and how they do things and encourage each hospital to figure out the best way for them to implement mutation testing. More often than not, I find myself pleasantly surprised as to how slickly and efficiently each hospital is able to apply these methods. Often I'm the one who ends up learning something new from these visits. I strongly advocate reflex testing. I believe it is only a matter of time before reflex testing becomes the standard of care in lung cancer. And I see absolutely no reason not to test all patients with a non-small cell lung carcinoma diagnosis. I also like to advocate that pathologists be the major players in implementing these methods, given their role in the lab and advanced knowledge of diagnosis. But it does not have to be only pathologists. The important thing is to choose individuals who are committed to this and will feel that organizing this test is their job.